Acute compartment syndrome of upper extremity, a new technique of perforators-based compartments release. This video was made in Bogotá, Colombia. Acute compartment syndrome occurs with the elevation of interstitial pressure in a closed facial compartment, resulting in microvascular compromise. This causes the perfusion gradient to fall below a critical value, leading to ischemia of the tissues within this confined space. Although any area of the body may be affected by acute compartment syndrome, the upper extremities account for more than 18% of observed cases. Compartment syndrome of the upper extremity may evolve from many different causes, traumatic and non-traumatic. In the upper extremity, the dorsal and volar compartments of the forearm are the most commonly affected. ACS of the upper extremity is caused by a myriad of factors, including fractures, bleeding disorders, constrictive dressing and casting, arterial injury, extravasation of the intravenous and intraosseous infusion, and regional anesthesia. Anything that causes increased volume within the confined facial space or restricts the compartment from expanding can cause ACS. The most frequent fracture types observed were the tibial diaphysis in 36%, the distal radius in 9.8%, the diaphysis of the forearm bones in 7.9%, and only 2.5% occurred following hand fractures. Compartment syndrome is caused by an elevation of pressure within a fibroosseous space, resulting in decreased tissue perfusion. The initial rise in the intercompartmental pressure causes increased extravascular venous pressure. Because of the lack of the musculature in the wall media, this relatively small rise in pressure causes the venule walls to collapse. The resulting decrease in hydrostatic gradient causes reduced local perfusion and increased interstitial pressure. This increased interstitial pressure in turn causes increased edema within the compartment, and this cascade of events repeats itself perpetually. Upper limb compartments anatomy. Anterior compartment of the arm. It's composed by the biceps, brachialis, and coracobrachialis muscles. It's covered by the brachial fascia, a continuation of the deltoid and pectoralis major fascia. It contains the radial, median, ulnar, and musculocutaneous nerves, brachial artery, and veins. Posterior compartment of the arm, composed by the triceps brachialis muscle, covered by the posterior brachial fascia, separated of the anterior compartment by the medial and lateral intermuscular septa and the humerus. It contains the radial and ulnar nerve and branches from the profunda brachii artery. Henry's or mobile wad compartment. It contains the brachioradialis, the extensor carpi radialis longus, and the brevis. No major neurovascular structures are located within this compartment. Proximally, the radial nerve, its two main branches, and the radial artery lie between this compartment and the anterior compartment. Superficial anterior compartment, surrounded by the antebrachial fascia, and it ends at the carpal canal. Contains the pronator teres, palmaris longus, flexor digitorum superficialis, flexor carpi radialis, and ulnaris. Supplied by the radial and ulnar arteries in the form of primary recurrent interosseous or collateral branches. Deep anterior compartment of the forearm. The deep volar compartment lies immediately volar to the interosseous membrane. It includes the flexor pollicis longus, the flexor digitorum profundus, and the pronator quadratus. The anterior interosseous artery from the ulnar artery, which may represent a significant source of circulation to the flexor digitorum profundus and flexor pollicis longus muscles. Volar compartment. Nerves. In the mid-forearm, the median nerve runs between the deep and superficial volar forearm compartments. Anterior interosseous nerve is found in the floor of the deep volar compartment. The AIN provides motor innervation to the deep flexors. In the mid-forearm, the ulnar nerve is bounded by the FDS, the FCU, and the FDP. Dorsal compartment of the forearm. The antebrachial fascia surrounds the extensor muscles and, along with the radius, ulna, and interosseous membrane, forms the dorsal compartment. It contains EDC, EDM, ECU, APB, EPL, EPB, EIP, and supinator muscle. Muscles are innervated by PIN, the deep branch continuation of the radial nerve. Wrist and hand. The hand has been divided into 6 spaces: the thenar, hypothenar, adductor, interosseous, carpal tunnel, and the digits. Clinical presentation. Paresthesias with signs of pallor, paralysis, pulselessness, and poikilothermia. Pain is characteristically out of proportion to the injury and with pace of stretching of the compartment contents. Pulselessness has been consistently reported as a late-stage finding. Tense swelling of the muscle structures, blistering, and necrosis. The diagnosis of compartment syndrome is usually made by history and physical examination, and then confirmed by the measurement of interstitial tissue pressure, although treatment is often guided by history and clinical examination alone. Doppler ultrasound is often used in the acute setting. It can identify a vascular occlusion causing swelling and pain, such as deep vein thrombosis. When used, the Doppler supports or refutes indeterminate arterial flow. MRI provides the grading of muscle involvement and highlights the likelihood of reversible ischemia. It's regarded as a superior image modality. Furthermore, MRI can be used for surgical planning due to its ability to precisely identify the location of the affected muscle groups and facial compartments. However, it has limitations, including cost, availability, and time for accuracy. Treatment. Medical treatment. Constrictive dressings should be loosened and the limb should be elevated to the level of the heart. Supportive splinting of the affected limb will assist in patient comfort. Medical resuscitation is critical for patients with compartment syndrome, particularly considering comorbidities associated with the condition. Fluid and electrolyte management, as well as careful monitoring of the renal function and for signs of coagulopathy are important. Fasciotomy. Release of all facial and epimysial envelopes, and decompression of all affected compartments and nerves. Careful search for separate subcompartments should be undertaken. Multiple skin incisions described. Sclerotomies, fasciotomies, external fixation, and nerve decompression may be indicated. Complications. Outcomes following compartment syndrome are dependent on injury severity, duration of the ischemia, and pre-injury status and comorbidities. Irreversible damage has been shown to occur after 8 hours in a canine model. Volkmann ischemic contracture, neurological deficit, infection, amputation, or death. We are also left with the question of whether the necrosis is also related to the fasciotomy technique. Acute compartment syndrome of upper extremity, a new technique of perforators-based compartment release. The objective of the design of the incisions is to take care of the flaps of the extremity, taking into account the distribution of the perforating vessels. In total, we must design 7 flaps. Forearm compartments release. Starting from distal to proximal with the release of the carpal tunnel, longitudinally affecting the superficial palmar fascia and posteriorly the transverse carpal ligament. Here we can visualize the carpal tunnel released and the median nerve inside. When starting with the release of the forearm, the dissection of the radial skin flaps must be careful while respecting the perforating vessels that are directed towards it. Dissecting delicately over the epitendon of the palmaris longus, it is necessary to ligate some communicating vessels between the radial and ulnar system. We continue with the dissection of the ulnar skin flap perfused by the perforators of the ulnar artery, which need to be preserved as well as the perforators of the muscle bellies severely affected during compartment syndrome, and which will be responsible for reperfusion after the release of the ulnar artery. After dissection of the ulnar flap, we proceed with exposure of the proximal antebrachial fascia, releasing it initially with a longitudinal fasciotomy followed by partial and segmental fasciectomies. Here we can observe partial and segmental fasciotomies and fasciectomies. We now proceed with the release of the entire radial artery perforator system to improve perfusion of the both muscle bellies and the skin flaps. With a mosquito clamp, we perform blunt dissection parallel to all the perforators that are detached from the radial artery. This requires displacement of the flexor carpi radialis medially, which allows to identify the perforating vessel system. Subsequently, we perform the same procedure for the release of the perforators of the ulnar artery, separating the superficial flexors in radial dissection. Then we proceed to the release of the deep flexors, also with blunt dissection, on the radial border of the superficial flexors, respecting the perforators of the radial artery that are directed mainly to the muscle bellies and performing the respective fasciotomies and fasciectomies. And we proceed in a similar way in the ulnar border of the superficial flexors. We continue with the release of the supinator extensor compartment of the forearm, which is performed by the same approach as above. Therefore, no other incisions are required. The important thing is to respect all the muscle perforators and skin flaps to avoid ischemia added to the compartment syndrome and therefore reduce the risk of necrosis. Finally, to complete the liberation of the forearm compartments, we free the pronator quadratus muscle, performing fasciotomy plus fasciectomy, and with blunt dissection, freeing the anterior interosseous bundle. It's important to preserve the perforators of the radial artery towards its radial edge. Arm compartments release. At the beginning of this section of the dissection, care must be taken with the cephalic and basilic veins over the antecubital fold, in addition to taking care of the perforators of the antecubital fold. In the arm, the perforators go in a transverse direction, so it's necessary to ligate them in order to reach both compartments through this approach. Through the medial approach, identifying the reference of the intermuscular septum, it is possible to perform the release of both the anterior and posterior compartments as shown in the images. As the dissection progresses, the medial cutaneous antebrachial and medial cutaneous brachial nerves must be identified and cared for. Subsequently, we will find the brachial fascia that needs to be released through fasciotomy and partial fasciectomies, taking great care not to injure the perforating vessels that are directed to the muscle compartments and that are perpendicular to the brachial neurovascular bundle. When releasing the fascia over the anterior compartment and preserving the perforators, it is important to identify and release the musculocutaneous nerve between the biceps and brachial muscles. Hand compartments release. If necessary and the compartment syndrome extends to the hand, we must begin by releasing the interosseous musculature through two longitudinal incisions, one in the second intermetacarpal space and the other in the fourth intermetacarpal space. These two incisions allow the release of all the interosseous compartments. To free the fascia, incisions should be made on the radial and ulnar border of the extensor tendons, followed by partial fasciectomies, and taking care of the tendon joints, the epitendon of the extensor mechanism, and the intermetacarpal vessels. To release the hypothenar musculature, we perform a longitudinal incision over the palmar and dorsal interface, immediately below the hypothenar fascia, and we will perform the release, making fasciotomies and fasciectomies, being careful with the ulnar collateral nerve of the fifth finger. Therefore, the release should be performed in the most posterior aspect of the compartment. To free the thenar musculature, we perform a longitudinal incision over the palmar and dorsal interface, immediately below the fascia of the compartment. We must perform dissection perpendicular to the approach with scissors to preserve the perforating vessels. Once a good exposure is achieved, fasciotomy and partial fasciectomy should be performed to free the compartment. Take-home messages. In the upper extremity, the dorsal and volar compartments of the forearm are the most commonly affected. The diagnosis is usually made by history and physical examination, and then confirmed by the measurement of the interstitial pressure. The main goal in the management of ACS is early release of all fascial and epimysial envelopes and decompression of all affected compartments and nerves. When performing the release, do not forget to perform the segmental fasciectomies while respecting the perforating vessels throughout the procedure to avoid a greater risk of necrosis of both the muscles and the skin flaps. If this video was useful for your learning, or if you have any comments, please send us an email.